Good evening, everyone. It's an honor as a nephrologist to talk about nephrological perspective of heart failure in a cardiology meeting of this nature. I thank the organizers for giving me an opportunity to share my views. Interesting topic, the role of ARNI in renal complicated patients. We all know as a nephrologist as well as a cardiologist that heart and kidney interact in a very complex and bidirectional manner, and many a times they're not clear to which is the primary organ to initiate the process, secondary organ involvement. And it is clinically categorized for the sake of clarity, the cardiorenal syndrome type 1 and type 2, which is basically treated by cardiologists, type 3 and type 4, which we call as renocardiac syndrome, which is basically treated by nephrologists, and type 5, which is a cardiorenal syndrome, which is being taken care by the critical care specialist. CKD, that is a chronic kidney disease associated with excess cardiovascular mortality, and it is said that heart failure contributes greatly to it, and hence any measure which can take care of heart failure is likely to influence the outcome of CKD patients. It is well known that RAS inhibition is the cornerstone of treatment of heart failure, particularly with a reduced ejection fraction, but that is limited by the rise of serum creatinine in many patients. So in this context, angiotensin receptor neprilysin inhibitor looks to be a novel agent which plays a key role in improving not only the cardiac outcome but also the renal outcome. The perceptual barriers that I find in the clinical practice when we try to interact with the cardiologist as well as the other physician in prescription of ARNI is the risk of serum creatinine rise, the risk of hyperkalemia, the possible impact of increased microalbuminuria which were noted in this landmark trial, and the absence of recommendation as yet in people who have heart failure with preserved ejection fraction or a GFR below 30, which is a common situation in patients which we deal in our day-to-day practice as nephrologists. As a nephrologist, neprilysin use in renal disease is considered to be beneficial for three reasons. It reduces the risk of heart failure related cardiovascular death. That is number one reason. Second reason is it has an additional BP loading effect, which is a kind of problem in many patients who have kidney disease with heart disease. And it is also known to have an impact on the progression of chronic kidney disease, and that may delay the need for renal replacement therapy, as is seen with many kind of ARBs or ACE inhibitors. So hence a nephrologist will use not only for heart failure management but also for the other things that we highlighted, that is BP reduction as well as reducing the progression of kidney disease with proteinuria. This is a well-known slide for cardiologists, but for nephrologists may not be that well known. The building blocks of therapy, the therapeutic targets of heart failure with reduced ejection fraction. The three basic things are beta blockers, ACE or ARB, and mineralocorticoid receptor antagonist. But moment the patient has a kidney disease, this basic blocks starts getting into a kind of block, etc. So far prescription is concerned. The ACE and ARBs can produce hyperkalemia and rise of creatinine. MRA, if it is used with a low GFR, there is a risk of hyperkalemia. So in this context, the drugs which are written down, like the finrenone is a new drug which is being talked about in the nephrological reports to be having less hyperkalemic risk compared to eplerenone or spironolactone, and maybe a drug which can be used in future kind of trials for therapy of patients who have heart failure with reduced ejection fraction as well as a CKD. Whenever we are not able to use ACE or ARB for particular reason of cough or any other reason, ARNI can be used. And for beta blockers, as a nephrologist, if the patient has a kind of some contraindication in the context of heart failure, ivabradine can be used to at least reduce the heart rate. The common drug prescription as a nephrologist we find is the SGLT2 inhibitor based on the reports that it is a drug which is it has got a beneficial effect on the heart and kidney. But this drug is not effective in a patient who has a GFR below 45 and should not be focused to treat heart failure with chronic kidney disease. On the contrary, IV iron has been found to be a very important kind of additional therapy even in absence of anemia if the patient has a low ferritin, and should be used as is appropriate. Whenever we are using the drug ARNI, it simultaneously inhibits the neprilysin and it blocks the ET1 receptor. And because of the inhibition of neprilysin, we get the enhancing effect of vasodilatation, blood pressure lowering effect, sympathetic tone gets reduced, aldosterone level gets inhibited. That is why we can get hyperkalemia, and has got many other benefits like reducing the fibrosis in the myocardium, reducing hypertrophy, and it has got a natriuresis and diuretic property which can take care of heart failure. And simultaneous blockage of RAS produces a kind of effect of inhibiting the vasoconstriction, which has a beneficial effect on blood pressure, aldosterone, hypertrophy, and sodium and water retention. So this is a kind of synergistic combination which has the beneficial effect more than it being used alone. If as a nephrologist I look at it, how the use of this neprilysin inhibition will protect the kidney in heart failure, we know that in heart failure the kidney is exposed to reduction in renal blood flow, meaning thereby the oxygen delivery is reduced, and there is an increased tubular reabsorption whenever there is a reduction in GFR. That means the oxygen consumption is increased. Inhibiting this effect by use of neprilysin, the natriuretic peptide increases blood flow, increases eGFR, and thereby decreases tubular reabsorption, which means that oxygen delivery is increased and oxygen consumption is reduced. So this is a kind of balancing the pathophysiological abnormalities in a patient when we are using this drug. One has to also remember that diagnosing heart failure in a chronic kidney disease is a very challenging matter. It is difficult to distinguish heart failure from volume overload. Similar signs and symptoms are seen in patients who has chronic kidney disease, particularly in the advanced stages of stage 3 to 5 when the GFR is below 60. It is said that early heart failure symptoms are underappreciated in patients with chronic kidney disease in general practice, and it is many times passed off as fluid overload. Kansas City Cardiomyopathy Questionnaire, which is a kind of way to at least get an extra yield of heart failure diagnosis, showed that 25% of patients had an extra diagnosis of heart failure when this questionnaire was used in a patient of CKD with heart failure. The biomarkers that we talked about in the preceding presentation are in context of kidney disease more prognostic than diagnostic. So hence this is not a good tool to make a diagnosis by itself. ECG, echo, chest X-ray, which are the which are the usual standard tests to make a diagnosis of heart failure, may not be diagnostic, and it has to be combined the clinical sense to make a diagnosis of heart failure. We know that heart is an endocrine organ and it releases the atrial natriuretic peptide, the brain natriuretic peptide, and even the C natriuretic peptide which is released from the vascular endothelium rather than from the atrium and ventricle. The interesting point in the slide that is shown is that the half-life of N-terminal BNP is roughly 120 minutes, in contrast to the half-life of ANP, BNP and CNP, which is in minutes, 2 to 3 minutes. Hence, NT-BNP is the marker that we usually look or measure to make a diagnosis of heart failure. And this level is not influenced by the use of ARNI, and hence it can still be a biomarker to be checked in patients of heart failure despite its limitation to make a diagnosis. Coexistence of heart failure and chronic kidney disease, we look at in the literature, it is said that chronic kidney disease is nearly found in 1/3 of patients of heart failure with a cardiorenal syndrome-like presentation. But if you look at the GFR below 60, it is said that about 60% of patients have a GFR below 60, which is contributed by AKI, prerenal state, and chronic kidney disease. In the landmark cardiac trial, that ADHERE trial, it was found that only 9% of patients had a normal GFR. That is to say that heart failure has a very close kind of association with kidney disease. Stepwise increase in heart failure incidence and mortality risk has been noted with each increasing stage of CKD from 1.6 to 14.9% in the recent report of National Kidney Foundation, the KEEP trial, Kidney Early Evaluation Program, where it found that as the stage of kidney disease worsens, the heart failure incidence worsens. This is a USRDS data, which is a very robust data where all the data are properly collected. It suggests that USRDS data estimates that 40% of patients with CKD have a heart failure as a cardiac diagnosis, in contrast to 20% of those who have no CKD. That is to say that 2 times incidence of heart failure is seen the moment the label of CKD is attached. Whenever we are using drugs like diuretics, ACE, ARB or ARNI, there could be a minor bump in serum creatinine when we are treating heart failure. But this may not be as serious as it is always thought, because this could be a kind of hemodynamic change, and this is the reason many times the clinicians stop the drug when the patient is on this drug. In this context, we are now going to have in the market this so-called NephroCheck, which is a kind of urine stick test which will measure the tissue inhibitor metalloproteinase 2 and insulin-like growth factor 7, binding protein 7, which if it is above the cutoff, it suggests that patient is not having a hemodynamic effect, it is an injury, and this is the situation where the drug has to be stopped. Coming back to the renal effects in the paradigm HF trial, which was highlighted and spoken, it was found that superior to enalapril in all important renal safety concerns. There was lower proportion of patients who had renal impairment, 3.3% versus 4.5%, which was significantly different. And hyperkalemia was lesser in patients who were on ARNI compared to the other one, but it was not statistically significant. Significantly fewer patients had to discontinue the drug because of renal impairment, 0.7% versus 1.4%. There was also noted that a slower rate of decline of renal function was seen in both diabetics and non-diabetics, which was remarkable. That is, it is a drug which slows down the kidney disease progression. And hence, it was concluded from the kidney point of view that it is more safe for kidney and it is also a good drug for cardiovascular benefit. This is a slide to look at in a different way, that when we are looking at the elevated serum creatinine from 1 to 2.5, how many people got it in ARNI group? It was 3.3% versus 4.5% in enalapril group, which was significant. Elevated potassium, the higher, more than 6, it was higher in patients who were on enalapril compared to ARNI, which was again statistically significant. Fewer patients in this ARNI group than in enalapril had to stop the drugs and because of renal impairment. That is to say that it is from all points of view, from the kidney point of view, it is safe. If you look at the change in GFR, it was found that the GFR is favorably affected in patients who are getting ARNI compared to enalapril. That is, the slope of decline of GFR is favorably affected. Look at diabetics versus non-diabetics. Both patients who were diabetics or non-diabetics were benefited with the use of ARNI, so far GFR is concerned. However, proteinuria was found to be slightly increased, which was not found to have an influence on the ultimate outcome of in the heart or the kidney. Pleiotropic benefits was seen in patients who received this drug. That is, the fewer patients required insulin, and the hemoglobin A1C was also better controlled in patients who received ARNI. And health-related quality of life was also better in patients who received ARNI. So the concept of using ARNI in CRS is similar to RAS inhibition. You should use in every patient with stable renal function with compelling indications like CRS type 2 and type 4. And we should aim to control the potassium with the use of newer agents like petadomal, which is going to be available, or PD support if required, or diuretics, and avoid MRA. Acute and unstable patients will be an absolute contraindication like patients with CRS 1 and 3. Because of lack of time, I am not presenting the two cases. The additional way to use ARNI is in a patient of proteinuria with kidney disease, where it was found that sacubitril valsartan has a similar benefit as with irbesartan. That is, this is not a drug which worsens the proteinuria, and this can be used in a patient of proteinuria CKD. I had an experience of using the drug where cardiologists will not use it. 24 patients in 1 year with where 4 patients on hemodialysis and 2 patients with peritoneal dialysis. None of the patients discontinued this drug because of hyperkalemia or hypotension. All patients had an improved quality of life and had a improved symptomatic improvement. One patient I used for a refractory hypertension, where the BP control was good. So in my experience, the use of this combination therapy in CRS is highly beneficial with reduced ejection fraction, and even in preserved ejection fraction with patient who has a kidney disease with GFR less than 30 and has an additional BP loading effect. Maximum benefits will be seen only with full dose. Albuminuria and hyperkalemia is not a big issue if MRA, which is a practice, is not used in a patient of kidney disease. And improved cardiac function, I feel, may ultimately improve the renal function and slow the decline. So to conclude, neprilysin inhibition as ARNI has a favorable effect even on the course of diabetic nephropathy, which has not been seen with any other drug besides heart failure. ARNI has a similar benefit as irbesartan in proteinuric CKD patients in short term and has better BP loading effect, and it is superior to enalapril in all important renal safety concerns in heart failure as seen in the paradigm HF trial. So this is a sensational drug, a Tehalka-like kind of drug. It protects the kidney and thereby it saves the heart, and that is the logo of World Kidney Day in 2011, that if you protect by any means your kidney, your heart is saved. So this is basically a teamwork. I will say that none of us is as good as all of us, and we need to have a kind of good cardio-renal kind of interactions in managing such patients. Thank you.